last talk of today, Visual Outcomes with New Generation Enhanced Monovision IOLs by Dr. UPSHAM Goel. Over to you, Dr. UPSHAM, sir.
Thank you, sir.
Yeah.
It's a pleasure meeting everyone and lovely hearing Gaurav's talk. So, why do we require these newer IOLs? Of course, we all know there's been a change in lifestyle, there's increased life expectancy, so you want better outcomes. From every surgery that you do, you want better outcomes. Now, the important thing to understand here is that the eye naturally, can you have a pointer? The eye naturally exhibits a certain tolerance for out of focus images. Now, that is something which is fantastic to know, that because of this property, we are able to create these extended depth of field or the EMV or the advanced monofocal lenses, because we are utilizing this advantage of accepting a slight defocus in the images that you get. Now, multifocal IOLs have been shown that they create glares and halos. So, that is the biggest problem with multifocal IOLs, and the most common cause for removal of these IOLs also has been glares and halos and decreased contrast. And the interesting thing is that 70% of eyes undergoing explantation of multifocal IOLs had uncorrected visual acuity of 20/20. Despite that, patients were not happy, and finally they had to be explanted. And all of us, I think, in this hall who have implanted IOLs would agree that there are hardly any patients who are unhappy with their monofocal IOLs, despite not having the depth of field and all. So, they have the limitations. Sab dikhta nahi, paas ka nahi dikh raha, dur you can see for distance, but you can't see for near, or vice versa. But they are not dissatisfied to the extent that they want a removal of the IOL. So, because of this ring problem, the EDOF IOLs were created. They work on the basis of creating a defocus curve here. So, you get a little, using that advantage of the neuroadaptation of slight defocus, that's how they work. And the advanced monofocal or the enhanced monovision IOLs also are based on the same principle of getting a larger defocus area. So, we decided to compare, because companies would obviously sell us the most expensive lens that they have. But so we decided to really check whether these lenses are they as good as they claim to be. So, we created this thing, we created these contrast charts and glare charts, and how it was done was that we presented a 6/19 size Snellen test type to the patient, and only three optotypes were used. The room is evenly illuminated at 4 lux, and the display monitor is the only source of illumination, and it is measured at 10 lux at 30 centimeters, and then in the separate chart it is 25 lux at 30 centimeters, and then we switch on lights to compare with what you normally see with driving situation. So, you have 875 lux at 30 centimeters. So, I just want to show you, this is the way we made the contrast charts. As you would see, this slide, this is 50% gray on 100% black. So, that's how it is, and then we reduce it, that's 30%, and you keep on reducing it on a logarithmic scale. So, this is typically among the last of the letters that the patient is able to read in those circumstances where you have the room lights adjusted and the brightness of the screen adjusted. So, this is your contrast chart. Then this is our glare chart number 1, where we have a central black area surrounded by a white area, and the patient is sitting at 3 meters distance and assessing the vision. And in the last situation, we switch on these light sources here, and so they give you 875 lux light, and which falls directly into the patient eye, and then we see how much are they able to see. Now, what did we find with all this thing? The beautiful thing we found was that, number 1, we were also measuring the pupil size to see how the IOL performance matched that with pupil. We all know that if a pupil size is about 2.5 millimeters, you do not use a multifocal lens. You do not have any advantage of using a multifocal lens. A monofocal lens will perform as good as multifocal or maybe even better, because there is no pupillary change. Unlike one of the doctors was insisting that pupil size is important, and we fully agree with that. So, with the group 1, the Oro patients, what we found was that near vision, so we did a distance vision correction, the best corrected visual acuity, which is here 6/6. Can I have a pointer, please? Pointer hai bhai? So it's not working. It's not working here. So the best corrected visual acuity is 6 by 6 in all these patients. And then with the distance vision correction, we measured at 12 inches, 18 and 24 inches. And this is what we found, that it was N5 and even N4 in the patients who had these advanced monofocal IOLs by Oro. The contrast charts are here and the glare charts are here. And now when you compare it with the monofocal IOLs, this was the reading here, and these are the readings here. N6, 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 and some cases N10 and N8. So, when we compare the two groups, what did we find? That near vision correction at 12 inches with distance vision correction varies from N4 to N6 with the Oro, and with the monofocal, and when I'm talking about mono, I'm talking about premium monofocal lenses. That's N6 to N10. And near vision at 18 is still N4, N6, and this goes here. And at 24 inches, this is N3 and N6 sometimes. And in the mono, it goes to N8, which means that these patients are able to see well from 12 inches right up to 24 inches, which is most of the work that they require to do. Contrast, if you see, now this is the most important thing which I'm trying to tell, that with the EMV lenses, unlike the EDOF and the multifocals, there is no decrease in the contrast. The contrast scores are equivalent to these, not statistically significant difference, but this is only scoring to be better. And glare with lights off is also the same, and glare with lights on. In all these parameters, the EMVs have shown to have an equivalent performance as that of monofocal. Then we use a defocus curve. I think you guys may all know about it. And this is the outcome of the defocus curve at minus 0.5, minus 1. And even to minus 1.5, you have log mar 0.2. So this is the performance of the EMV. And when you compare with this on a monofocal, you can see that with a minus 1.5, it goes to log 0.3. So this is the analysis that the Orolab AMVs show overall better depth of field as compared to a monofocal. The contrast sensitivity and glare testing are equivalent, if not better. The EMV demonstrated much reduced spectacle dependence. None of the patients said, especially after bilateral, and the best part is all this analysis we have done is with one single eye, not with both eyes. And with both eyes operated with the 0.5 defocus set off, nearly all patients are spectacle free. This is important, that pupillary size and mobility. This is something all of you should do. Look at the pupil size and look at the pupillary mobility before you operate the patients. If for any reason patient has a fixed pupil or a larger pupil which is not reacting, then please do not go for any kind of a multifocal lens. Assessment of dynamic pupil is, and how to really assess what is the pupil size is one of the toughest jobs to do because it keeps changing from time to time. But overall, as we compare, things look pretty good. And today, even the ESRS agrees that EMV IOLs will become the standard of care for future. Thank you, gentlemen.
Thanks a lot, Dr. UPSHAM. Excellent.